Welcome. In the previous sessions, we discussed about the more common diagnostic methods for patients with retinal disorders, and in this session, we'll be discussing about the less common but nevertheless important diagnostic methods. And we have discussed the underlying physiological functions of the retina, which these tests assess in the session on physiology of neurosensory retina. Dark adaptometry measures the rod and cone absolute threshold sensitivity and the time to recover this sensitivity when the subject is tested in a dark environment after being exposed to bright light. And it is performed with a Goldman-Wickert's adaptometer, in which the subject is presented with stimuli of varying intensities over time to detect the change in threshold intensity over time. And this is the dark adaptation curve, which we have discussed in the session on physiology of neurosensory retina. So here we see that the threshold intensity decreases over time to reach a minimum called absolute threshold sensitivity, with this point representing the absolute threshold sensitivity of cones and this point representing the absolute threshold sensitivity of rods. Dark adaptometer is used to evaluate the function of rod photoreceptors in patients complaining of nyctalopia or night blindness. And although subjective, dark adaptometry can complement ERG findings. Because being a focal test, dark adaptometry may be more sensitive than ERG, especially early in the disease process. Coming to color vision testing, in patients with optic nerve diseases, particularly demyelinating optic neuritis, color vision is more severely affected than visual acuity. And color vision deficiency can persist even after resolution of the disease and recovery of visual acuity. In patients with macular diseases, color vision and visual acuity tend to be affected to a similar extent, except in cone dystrophy, where color vision is more severely affected than visual acuity. Acquired retinal and choroidal diseases tend to affect the blue-yellow axis more severely, whereas acquired optic nerve diseases tend to affect the red-green axis more severely, and this is important to remember. We have discussed about axis of color opponency in the session on physiology of neurosensory retina. On the other hand, deficiency in discrimination in the red-green axis is most commonly congenital, and deficiency in discrimination in blue-yellow axis is most commonly acquired, which is also important to remember. And testing for color vision deficiency should be done unilaterally for each eye. Among the color vision tests, we have anomaloscope, pseudo-isochromatic plates, and panel tests. Anomaloscopes, as seen here in this photograph, uses light sources, unlike pseudo-isochromatic plates and panel tests, which use reflected light from test objects instead. And because it uses light sources, anomaloscopes are considered as the most accurate test for classifying color vision defects, particularly congenital red-green color vision defects. Through the anomaloscope, the subject sees a split screen, half of which shows a test color, whose brightness can be adjusted, and attempts to reproduce this color in the other half by mixing two primary colors in various proportions. The anomaloscope can detect deficiencies in both the red-green axis and the blue-yellow axis, and this is an important mnemonic, RGBPDT, which tells us that the proton axis refers to the long wavelength cones which subserve red color perception, the deuter axis refers to the M or the medium wavelength cones which subserve green color perception, and the triton axis refers to the S or the short wavelength cones which subserve blue color function. And protanopia refers to patients in whom L cones are absent and who are not able to perceive red color. And in anomalous patients, the peak sensitivity of the L cones is shifted, and the description is similar for deutered anopia, deutered anomalous, and tritanopia and triton anomalous. In Rayleigh test, the test color is yellow and the two primaries are the red and green, so the brightness of the yellow is to be matched with varying proportions of red and green. And the result of the Rayleigh test is plotted on a chart, with the y-axis corresponding to the brightness of the yellow test color and the x-axis corresponding to the ratios of the red and green colors in the red-green mixture, with the percentage of the green color in the mixture increasing from left to right, and percentage of red color in the mixture decreasing from left to right. The graph has an M line along which protanopes who lack L cones and have normal M cones can match any brightness of the yellow color, and an L line along which dotted anopes who lack M cones but have normal L cones can match any brightness of the yellow test color. At the intersection of the L line and the M line, normal subjects match the brightness of the yellow test color. Anomalous patients who have altered spectral sensitivity of the L cones match the brightness of the yellow test color along the M line but with higher red-green ratios than normal, and dotted anomalous patients who have altered spectral sensitivity of the M cones match along the L line but with higher green-red ratios than normal. In the Moorland test with the anomaloscope, the blue-yellow axis is assessed, which is served by the short wavelength or S cones. The test color is cyan, which is actually a mixture of blue and green and whose brightness is plotted along the y-axis, and the primaries are violet and blue, which can be mixed in various proportions by the patient to match the brightness of the cyan. The Moorland chart has two lines, the S line and the LM line, and tritanopes who lacked S cones and patients with acquired macular defects in whom the S cones are preferentially affected match the brightness of the test cyan color along the LM line. Patients with X-linked achromatopsia who lack L and M cones but have S cones and rods match the brightness of the test cyan color along the S line. And complete achromatopsia patients who lack L, M and S cones but have rods match the brightness of the test color along the rod line both in Moorland test and Rayleigh test. And this is the zone at the intersection of the S line and the LM line where normal subjects match the brightness of the cyan color. Now we come to the more familiar pseudo-isochromatic plates, which are the most common tests performed in the clinic for detecting color vision deficiency. And we have the Ishihara plates, which detect abnormalities in red-green color discrimination, which is very important to remember, and has a 90 to 95% sensitivity in detecting congenital color blindness, which is most commonly red-green defect in nature. And then there are the Hardy-Rand-Richter plates as shown here in this photograph, which can detect abnormalities in both the red-green and blue-yellow axis. Pseudo-isochromatic plates have numbers or figures made up of colored dots on a background of differently colored dots, and individuals with color deficiency either cannot detect the number or figure or see an alternate number or figure based on brightness. These tests should be performed under illumination mimicking sunlight, since they are based on reflected light from the test object, and fluorescent lights are not recommended for these tests. And this is very important to remember. And pseudo-isochromatic plates are considered as sensitive screening tests to detect color vision deficiency, can be quickly performed but cannot classify the deficiency as accurately as anomaloscopes and panel tests, which is also important to remember. We'll discuss the Ishihara plates in a little more detail as they are the most commonly used in the clinic. The original Ishihara test contains 38 plates, but 10, 14 and 24 plate Ishihara tests are also available, and the Ishihara plates can be classified as follows. The first and the last plates are the demonstration plates, which normal subjects and patients with red-green color defects read similarly. Then there are the transformation plates, in which proanomalous and dotted anomalous patients read differently from what a normal individual reads, and proanopic and dotted anopic patients do not perceive anything. Then there are the vanishing plates, which proanomalous, proanopic, dotted anomalous and dotted anopic patients cannot read. Then there are the hidden digit plates, in which proanomalous and dotted anomalous patients perceive digits, but normal subjects, proanopic and dotted anopic patients do not. Then we have the tracing plates, in which instead of reading a digit, the subject needs to trace a line. Then there are the diagnostic plates to determine the type of red-green color vision defect and its severity. Then we have the panel tests or the arrangement tests, which are based on the subject arranging caps of different colors or hue, and in each row the first and the last cap are fixed in position, and the remainder of the caps have to be arranged by the patient according to his perception of color transition from the first and the last cap. Such tests are available on the internet and the listeners can try it out themselves. Panel tests assess color discrimination along both red-green and blue-yellow axes and are considered more accurate in classifying color deficiencies as compared to pseudo-isochromatic plates. But since it is also based on light reflected from test objects, it should be performed under illumination mimicking sunlight, and special devices are available which provide the appropriate illumination to perform these tests. The two commonly employed panel tests are the Farnsworth-Munsell 100 hue test and the Farnsworth panel D15 test. The 100 hue test have 85 colored tablets or caps instead of the original 100 because 85 caps have been found to be sufficient, and these 85 caps represent the entire spectrum with their colors differing by the minimum amount of 1 to 4 nanometers, which can be discriminated by a normal individual, and the tablets are divided into 4 sets, with the first set containing 22 tablets and the remaining 3 sets containing 21 tablets each. The 100 hue test is very sensitive for detecting and classifying color vision defects, but is time consuming and tiring for the patient, and because of the close spacing of colors in the 100 hue test, it is considered to be a chromatic discrimination test. The result can be plotted on a graph, and the color deficiency can be classified by the pattern on the graph. So for each numbered cap, the graph is marked at the point corresponding to a number which increases from the center to the periphery, and this number is the average of the difference of the number of the cap representing that line and the number on its two adjacent caps. So the number of abnormal marked points depend on the number of tablets misplaced, and the point is marked further in the periphery when the distance of displacement of the cap from its position in the normal order is larger. Patients with congenital red-green deficiency have characteristic patterns on the graph, but patients with acquired diseases have more irregular patterns on the graph. So these are how the graphs look like in a normal subject, and these show irregular patterns in a patient with acquired color vision deficiency. In the Farnsworth-Munsell 100 hue test, 3 parameters can be assessed separately. One is the confusion angle, which is the axis along which the deviations are maximum, and a positive confusion angle indicates a proton defect. A confusion angle between -12 and -65 degrees, as in this case, indicates a Doyton defect, and if the confusion angle is even less, it indicates a Triton defect. S index is the measure of scatter of the deviated points, and as we have mentioned, the scatter is less in congenital red-green color deficiencies and more in patients with acquired color deficiencies. And the C index, which considers the magnitude of total error made by a subject and depends on both the number of tablets misplaced and the distance of misplacement from the normal order. 16% of normal subjects have a good C index with a total score of 0 to 4. 68% of normal subjects have an average C index with a total score of 16 to 100, and 16% of individuals have a weak C index with an average score of more than 100. In acquired color vision defects, partition tests can be done with the 100 hue test to determine whether red-green, that is the LM cones, or the blue-yellow, that is the S cones, are more affected. And separate scoring is done for caps whose correct ordering require intact red-green axis and for caps whose correct ordering require intact blue-yellow axis. The Farnsworth panel D15 test consists of only 15 tablets instead of 85, but covering the entire spectrum. So it is quicker than the Farnsworth-Munsell 100 hue test, and here also the subject is asked to arrange the tablets according to their colors between the two tablets which are fixed in position at either end of the row. The D15 test may miss subtle deficiencies in color discrimination which may not be significant in most situations and professions. And because of the wide spacing of colors between the adjacent caps in the D15 test, the D15 test is considered as a color confusion test. And in addition to the 100 hue and the panel D15 test, other panel tests are also available. Then we come to contrast sensitivity testing, and contrast is the difference in brightness of an object as compared to its background. So among these three objects, this one has the highest contrast and this one has the lowest contrast. And contrast sensitivity is the ability of a subject to discriminate objects with low contrast against its background. Snellen visual acuity is a test having optotypes with 100% contrast as represented by this object. But most visual tasks in everyday life need to be done under less than 100% contrast. And loss of contrast sensitivity may cause visual symptoms out of proportion to the measured Snellen visual acuity. And activities which are particularly affected by poor contrast sensitivity include reading light-colored prints, seeing in foggy conditions, and recognizing faces. So contrast sensitivity measurement can detect loss of visual function when Snellen visual acuity is found to be normal. Contrast sensitivity can be assessed either with sinusoidal gratings as shown here by these two photographs or with optotype charts. In a sinusoidal grating chart as shown here in this photograph, the contrast has some peak value which decreases to 0 vertically and also horizontally and appears like a bar chart with blurred edges. Contrast increases in the negative y direction and the spatial frequency between the blurred bars increase in the positive x direction. And in this chart, the spatial frequency remains the same in each row, but the contrast decreases from left to right. So in this chart, the patient has to locate along each bar the minimum contrast at which that bar disappears, and in this chart, the patient has to detect the orientation of the gratings, whether left, right or up. In contrast, in the Snellen visual acuity tests, the spatial frequency of the optotypes increase from top to bottom of the chart, while their contrast remains constant near a value of almost 100%. So with this sinusoidal grating, for each spatial frequency, the minimum contrast is recorded at which the blurred bar can be identified and then disappears. And this minimum contrast is called contrast threshold for that particular spatial frequency. And the lower the contrast threshold, with less contrast occurring in the positive y direction, the higher is the contrast sensitivity for a specific spatial frequency. And the contrast threshold for each spatial frequency is plotted and is called the contrast sensitivity function. Contrast sensitivity is maximum for a certain spatial frequency at around 3 to 5 cycles per degree and falls when the spatial frequency either increases or decreases from that value. And spatial frequency grating is considered superior to optotype charts for contrast sensitivity testing but are difficult to administer and reproduce. Optotype charts such as Pelliropson and Regan are easier methods to analyze contrast sensitivity in the clinic. In Pelliropson chart as shown here in this photograph, the spatial frequency remains constant, equivalent to 20 by 60 or 6 by 18 on the Snellen visual acuity, but the contrast decreases from left to right and from top to bottom. And the optotypes are in groups of 3 with the same contrast within a group, and the group with the lowest contrast, of which an individual can read 2 or 3 letters, is considered to determine his or her contrast sensitivity. And the logarithmic value of contrast sensitivity, with the contrast sensitivity expressed as a percentage, with 100% being normal, is given for each group. In a full 8-line chart, the log values range from 0.05 to 2.3, and an individual with a normal contrast sensitivity should be able to read the group with the log value 2, and 100 is the number whose log value is 2, and a score of less than 1.5 represents visual impairment, in which the minimum contrast group which the patient is able to read is this one or a group with a higher contrast. And in Regan chart, both spatial frequency increases and contrast decreases from top to bottom. Factors affecting contrast sensitivity function include room illumination, which as we have mentioned also affects color vision testing. And contrast sensitivity should be tested with a normal room illumination. With low room illumination, Peak contrast sensitivity occurs with a lower spatial frequency as compared to that with normal room illumination, and the contrast thresholds are higher for every spatial frequency as compared to the contrast thresholds in normal room illumination. Other factors which can affect contrast sensitivity function are refractive error and pupil size, with contrast sensitivity decreasing with both large and small pupil sizes. Contrast sensitivity function testing is useful in determining effect of visual impairment on everyday tasks, and contrast sensitivity affects visual function even when visual function is adjusted for associated loss of Snellen visual acuity. But there is no pattern of contrast sensitivity function abnormality specific for a certain pathology, and so contrast sensitivity function testing cannot distinguish between media, retinal and neural pathologies, and this is important to remember. Abnormal CSF function is found in a large number of ophthalmic conditions such as corneal edema, cataract, and in early cataract, contrast sensitivity may be affected while Snellen visual acuity is spared. Retinal diseases and conditions such as retinitis pigmentosa and central serous retinopathy affect contrast sensitivity more than Snellen visual acuity, and macular degenerations affect Snellen visual acuity more than contrast sensitivity. Other conditions which can affect contrast sensitivity include glaucoma, optic neuritis, and amblyopia. Coming to visual field testing, and we will be discussing 4 modalities of visual field testing: microperimetry, Amsler's grid, standard perimetry, and preferential hyperacuity perimetry. Microperimetry first determines the location of fixation, which may be eccentric in macular diseases, and then measured sensitivities in various areas of the central retina, and so can show spatial relationship of scotomata with the fixation, whether normal or eccentric. And these devices use retinal tracking to detect ocular movement and correct for changes in fixation due to ocular movement, and so is particularly useful for patients with macular diseases who have fixation issues. Microperimetry report displays the sensitivities of various retinal locations on an image of the retina, and so allows correlation between structural and functional defects at various locations in the retina. Microperimetry can detect small areas of central foveal sparing in patients with central scotoma, which can be improved with low vision aid devices. Amsler's grid is an extremely important tool to assess the central visual field, and 7 types of Amsler's charts have been described. The black on white or the white on black grid is the most common one to be used. The white on black Amsler's grid as shown here in this photograph was the original one, but a black on white grid as shown here in this photograph is more commonly used, as multiple printouts can be more easily taken, and a patient requires multiple copies of the Amsler's grid to serially record defects in his central visual field. The Amsler's grid is a 10 cm by 10 cm grid with 20 by 20 squares, each having sides of 0.5 cm. And Amsler's grid testing should be done by viewing the Amsler's chart from a specific distance of 14 inches. At this distance, each square subtends 1 degree. Amsler's grid is used at home by patients with macular pathology between eye examinations in the clinic to self-monitor for disease progression, and this is very important to remember. The patient should use corrective glasses with near correction, and the test is done unilaterally for each eye by covering the other eye. From the specified distance of 14 inches, the patient maintains fixation at the central dot, and while maintaining fixation at the central black dot, the patient attempts to note any missing areas or distorted areas within the Amsler's grid, and the abnormal areas thus found should be marked and that grid preserved, and for the next session a fresh Amsler's grid is similarly used, and so comparison of area marked in sequential grids enables early detection of disease progression, and sensitivity of detecting abnormality can be increased by using a red grid on a black background as represented by this grid, or by using crossed polarization filters which reduce the contrast of the chart. Unlike microperimetry, Amsler's grid cannot detect eccentric fixation, and it has been found that Amsler's grid may miss almost half of all central and paracentral scotomas due to perceptual filling in of these defects, which does not occur with preferential hyperacuity perimetry. Standard automated perimetry, which we have discussed in the section on glaucoma, can also help in elucidating the extent of visual dysfunction in retinal disorders. Preferential hyperacuity testing, also called preferential hyperacuity perimetry, is based on testing hyperacuity or vernier acuity, which detects subjects' ability to detect spatial location of objects, and the stimuli as shown here in this photograph consists of a straight line of dots, except some which deviate from the straight line, and these are the artificially deviated dots by the machine, and the subject has to detect the artificially deviated dots and report whether he or she sees other deviations from straight line, which are called pathological deviations occurring due to macular lesions. PHP is said to be more sensitive than Amsler's grid in detecting early onset of neovascularization in age-related macular degeneration, and as we have mentioned, PHP avoids perceptual filling in, which occurs with Amsler's grid, and home-based PHP testing devices are available. In retinitis pigmentosa, the earliest defects are small localized defects between 20 and 25 degrees from fixation, which progressively coalesce to form a ring scotoma. Then the portion of the visual field peripheral to this ring scotoma is affected, leaving behind a central island of spared visual field, and in very severe retinitis pigmentosa, the central field is also lost. Cone dystrophy shows a central scotoma on visual field testing, often with sparing of the foveal center. Stargardt's disease shows two patterns of visual field defects. One is a dense ring scotoma with central sparing, and the other is a dense central scotoma. In guided atrophy of retina, there is peripheral constriction of the visual field. In diabetic retinopathy and retinal venous occlusion, visual field defects correlate with areas of retinal non-perfusion and edema, and following panretinal photocoagulation, peripheral constriction of the visual field occurs. In central serous chorioretinopathy, mild central depression of the visual field is often found, and even after resolution of subretinal fluid, residual perimetric defects remain in majority of patients. In early AMD, visual sensitivity is decreased in locations of disrupted IS-OS junctions and drusenoid RP elevations, so these are said to be biomarkers of diminished visual function. In geographic atrophy, visual field testing can help in assessing the rate of progression. In neovascular AMD, a dense central scotoma usually occurs, and visual sensitivity often improves after PDT and anti-VEGF therapy, but has not been found with lutein supplementation. Retinal sensitivity has been found to decrease following internal limiting membrane peeling during vitreoretinal surgery, and this occurs more frequently when indocyanin green is used as compared to use of brilliant blue G dye for staining the internal limiting membrane. Among drug toxicities, visual field defects with hydroxychloroquine is typically a ring-like scotoma in the central area of the retina, and this is important to remember. 10 to white on white testing protocol on the Humphrey Visual Field Analyzer is recommended for screening for hydroxychloroquine toxicity, and this is very important to remember. Thyroidazine toxicity of the retina causes a central scotoma, and toxicity due to vigabatrin, an anti-epileptic drug, causes loss of peripheral visual fields. Visual field testing can enable us to differentiate between retinal detachment and retinoschisis, with retinal detachment typically having sloping isopters on kinetic perimetry, and retinoschisis having a dense scotoma with steep isopters. And following surgical repair of retinal detachment, recovery of visual function is usually incomplete, particularly with long-standing retinal detachment, and it has been seen that cone function recovers earlier as compared to rod function, and central visual field defects are more likely to occur when posterior retinotomies as compared to anterior retinotomies are done to drain subretinal fluid during vitrectomy. Choroidal melanomas as well as choroidal metastases usually show dense scotoma, but choroidal nevi show only subtle field defects, and so visual field testing can be a supplement to differentiate choroidal melanomas and choroidal metastases from choroidal nevi. To recap the salient points, dark adaptometry performed with a Goldman-Vickers dark adaptometer evaluates the ability of the rod system to recover in a dark environment following exposure to a bright environment. In optic neuropathies, color vision is more affected than visual acuity, but in macular diseases, color vision and visual acuity are usually affected to the same extent, except in cone dystrophy, where color vision is more affected. Acquired optic neuropathies usually affect the red-green axis, and acquired macular diseases usually affect the blue-yellow axis. On the other hand, red-green color deficiency detected in a patient in the clinic is most commonly congenital, whereas blue-yellow color deficiency is most commonly acquired. Anomaloscopes are the most accurate tests to classify color vision defects. A test color whose brightness can be adjusted is matched by the subject by combining two other colors. Both red-green and blue-yellow axes can be evaluated. Pseudo-isochromatic plates are rapid and sensitive tests to detect color vision defects but are less effective in classifying them. Ishihara plates are used to detect red-green color deficiency, and Hardy-Rand-Rittler plates are used to detect both red-green and blue-yellow color deficiencies. Panel tests or arrangement tests can classify color vision defects in both red-green and blue-yellow axes. Farnsworth-Munsell 100-hue test is more detailed and time-consuming and detects errors in chromatic discrimination. Farnsworth panel D15 test can be performed more quickly and is considered as a test to detect color confusion. In several ocular disorders, such as early cataract, contrast sensitivity is affected more severely than Snellen visual acuity, as Snellen visual acuity is a test with 100% contrast between the target and its background. Contrast sensitivity function denotes how contrast threshold, which is the minimum contrast detectable between target and background, varies with spatial frequency. Contrast threshold is maximum at 3 to 5 cycles per degree, and contrast sensitivity can be assessed with sinusoidal gratings and optotype charts. Amsler's grid is a simple and extremely important test in patients with macular degenerations to detect further deterioration early on. It is a home-based test which is performed by the patient himself or herself regularly between clinic visits. Microperimetry allows structure-function correlation by overlapping the visual field data on a fundus photograph. Microperimetry can detect eccentric fixation, which Amsler's grid cannot. Preferential hyperacuity perimetry is based on hyperacuity or vernier acuity testing, in which spatial locations of targets have to be determined by the subject. Home-based PHP devices are available, and PHP can avoid errors due to perceptual filling in, which occurs with Amsler's grid. Thank you for listening.